Well, welcome again. It's good to have you along for the ride. One of the things I kind of like about this uh, way we're doing this GI module is that I finally get a chance to do something I've wanted to do for a while, and that's talk about pediatric patients. Because we tend to give our pediatric patients kind of short shrift here in medical school. And as you'll hear plenty of times in the future, if you haven't heard it already, our children are not just small adults. They have their own set of pathologies, their own set of problems and diseases. And plus, I kind of like the little ankle biters anyway. So sit back and enjoy the ride. Let's talk about imaging of pediatric gastrointestinal disease. So the objectives, there's a lot of words on here, but basically they're pretty much the same objectives for the most part, uh, just different disease processes. And the disease processes are underlined for you. Now I'm only going to signpost two lectures on this presentation, but this first lecture especially I think is very important, and that's Dr. Nunn's embryology of the gastrointestinal system that you received clear back in in semester one, week 8. I've pulled out slides for you I've noted slides that are specifically referring to some of the disease processes we'll be speaking about. But I would highly encourage you, and I know I say this on each lecture, but this one especially, I would highly encourage you to go back and review this lecture because much of the embryology has direct pertinence on these congenital diseases. And these are the type of things that you might find yourself confronted with on a step examination or a comp examination. What is the embryologic basis of this disease? What is the basis of malrotation, for instance? Or what embryologic remnant is the Meckel's diverticulum? Things like that. And so I would encourage you to go through Dr. Nunn's embryology of the gastrointestinal system and make sure you understand that, because you'll be seeing some things from this. Again, I can almost guarantee it. And then again, this lecture is written to correspond with Dr. Malik's pediatric gastrointestinal lectures that were done on that are in this same e-college folder. We're going to start off with esophageal atresia and tracheoesophageal fistulas. And we really need to include both of them together because these tracheoesophageal fistulas, these congenital tracheoesophageal fistulas, have an associated esophageal atresia. And there's basically 4 types of tracheoesophageal fistula. We're going to not really consider this type E too much. That's just esophageal stenosis. Esophageal stenosis can be due to a number of things in addition to a congenital stenosis, but that they present a little bit differently. So what we're going to be more concerned with is type A through type D. Now, I don't care specifically if you memorize what is type A, what is type B, and so on. But what I do care is that you understand the physiology behind this and how this presents on x-rays and how we can determine the type of fistula and esophageal atresia that is present on a child's study. So type A, the first type, is just esophageal atresia without a fistula. And by esophageal atresia, what we mean is the mid portion of this esophagus just has not formed. And so you have a proximal blind-ended pouch that extends from the stomach into usually the proximal or into the cervical esophagus or the proximal thoracic esophagus. And then you have the distal part of the esophagus that's attached to the stomach, but there is no communication between those. And that's what we mean by esophageal atresia. We can see the next type is the exact same thing, except in this case there's a little fistula or a little tract between the esophagus and the trachea. The most common type, almost 86% of the time, is this type C esophageal atresia with tracheoesophageal fistula. Again, you have the blind-ended pouch that does not communicate with the trachea, but you then have the distal esophagus that communicates with the trachea. So there's a distal esophageal fistula. So the proximal esophagus is a blind-ending pouch with no fistula. Distal esophagus has a tracheoesophageal fistula. And then the final type is this type D, in which there is esophageal atresia with both proximal and distal fistulas. Now, let's think about what that's going to do on x-rays. And one thing I want to mention too is if you look at this esophageal atresia without fistula and the esophageal atresia with distal tracheoesophageal fistula, that is going to compose 95 or so percent of your esophageal atresia and tracheoesophageal fistulas. So these are the two that you really should know the best. But let's think about what's going to happen on X-ray and in the patient's life. Say they have an esophageal fistula, a type A fistula, where they have this proximal pouch. Whenever they take feeding, that's going to go into the pouch. The pouch is going to get distended, it's going to be filled up, and the patient's going to regurgitate that. You're not going to get that feeding into the stomach. You're also not going to get any air into the stomach because there is no communication between the trachea or the proximal esophagus. Babies swallow a lot of air, but in this case, if the baby swallows air, it can't get into the stomach. So they're going to have an airless stomach. This type C fistula, again, you have no communication up top, and so the baby will take in formula or take in feedings and then regurgitate it out. It's not going to keep those feedings in there. But because there's this fistula between the trachea and the stomach, you should get an air distended stomach. In fact, it'll be more distended than if the baby was just swallowing air in a normal esophagus, because you're constantly having that breathing going on. And so you'll get a air distended stomach, but you can't pass, for instance, if you try to pass a nasogastric tube, it will not pass farther than the end of this pouch. Now, what happens if we have one of these pouches, one of these esophageal atresias, but we have a fistula of the proximal aspect? Well, if the baby feeds, most of that's going to come back out, but some of that is likely to go through the fistula into the trachea, and the baby will experience some respiratory distress, coughing, dyspnea. They may have some cyanosis because they are getting food, basically, their feedings, into their lungs, into their bronchi. So this is the presentation of some of these tracheoesophageal fistulas. So let's look at kind of how the patient presents to us. First of all, prenatally. On a prenatal ultrasound, a patient with esophageal atresia cannot swallow the amniotic fluid like they normally do. And so we get what we call polyhydramnios. Poly means a lot of, basically. Hydra means water or fluid. Amnios is the amniotic fluid. So it's a lot of amniotic fluid. You know, the baby can't swallow that, and so that it doesn't get through the GI tract. And therefore, we see a lot of fluid out within the gestational sac, but the stomach is very small because instead of the fluid, the amniotic fluid that the patient normally swallows, all we see in the stomach are just the excretions by the gastric mucosa. And if the patient has one of those proximal fistulas, you may have a little bit of fluid in the stomach from that. And so that's a kind of our most common finding on prenatal ultrasound. Now, after the baby is born, what do we see? Well, the first thing we see is excessive drooling. Why? Again, because the baby can't swallow. And so that comes up. The drool comes up. Now, babies drool. That's kind of what they do, and but this is just constant excessive drooling. Obligate regurgitations of feeding. So, what I'm saying by obligate is that the patient regurgitates every time they feed, not some of the times like most babies do, but every time they feed, they regurgitate the feedings, and if they don't have a fistula, they'll regurgitate all of the feeding. Even if they do have a fistula, they're going to regurgitate most of the feedings because those fistulous tracts are quite small. Again, those babies with the proximal tracheoesophageal fistula are going to have respiratory distress, cyanosis, coughing, wheezing, shortness of breath. The distal esophageal fistulas lead to excessive bowel gas. And again, we have no gas in the abdomen if we don't have that distal esophageal fistula. If all there is an esophageal atresia or proximal esophageal fistula. Now, babies with esophageal atresia and tracheoesophageal fistulas usually have some other congenital abnormality. Over 70% of babies have another congenital abnormality, with cardiac abnormalities being the most common. So we might see atrial septal defects or ventricular septal defects or patent foramen ovale, or even more serious valvular defects or hypoplastic left heart, things like that. One of the mnemonics that you can remember of some of these abnormalities, congenital abnormalities that seem to go together, is VACTERL, VACTERL. VACTERL stands for vertebral anomalies, so the patient might have hemivertebra, just partially formed vertebra. Anorectal abnormalities, and this is pretty common with patients with esophageal atresia. They might have anal atresia, in other words, the anus just may never form, or they may have an imperforate anus, and where you see an anus but it doesn't connect with the remainder of the bowel, with the rectum. And one way we can look and see if we have an imperforate anus is we tilt the baby head down, and if the baby has gas within the bowel, we can see that gas going all the way to the rectum. If we put a rectal thermometer in the baby, then we see there's this area here where there's just kind of blank space between the air and the rectal thermometer, and that's the distance that we don't have an anal canal. So anorectal, imperforate anus, anorectal abnormalities. We mentioned cardiovascular abnormalities and tracheal esophageal fistulas and atresias. These patients can have renal abnormalities, abnormalities of the kidney, and limb abnormalities, primarily radial ray abnormalities. So the patient's in normal anatomic position. It'll be the lateral aspect of the arms and the thumb side of the hands. They may be missing thumbs or have bifid thumbs and things of that nature. Okay, so how do we diagnose these? Well, if the patient has an esophageal atresia, if we attempt to put down an NG tube, a nasogastric tube, it's not going to go into the stomach because you have that blind ending pouch. And so we put this nasogastric tube in, and it only comes down to, in this case, the proximal thoracic esophagus. And this is pretty typical of where this occurs. In this case, the baby does not have gas in the stomach, so we have an esophageal atresia, no gas in the stomach, and so this baby has no distal tracheoesophageal fistula, and there's no way for gas to get into the stomach. Now we have another baby, and again, we have a nasogastric tube, and this time it has come down and curled up within the esophageal pouch, the atretic proximal esophagus. But we do have gas in the stomach. Then that tells us that we must have a distal tracheoesophageal fistula, and this would be one of those type C or type D defects with this type C, the esophageal atresia with a distal tracheoesophageal fistula being the most common of the defects. So we can get a good idea of what's going on with a baby like this. Now, why doesn't the the nasogastric tube go into the fistula? It's just because these fistulous tracts, again, are small. They're at an acute angle, but mainly they're small, and the nasogastric tube just won't fit through them. We try to avoid barium swallow on these patients. There's no reason for it usually, and the patient can, they will regurgitate the barium and can possibly aspirate, or if it goes to the tracheoesophageal fistula, it can aspirate, and that could lead to problems within the baby. But if it's absolutely necessary, if for whatever reason the diagnosis is difficult to make, you can do barium swallow as long as you're at a place that can do some emergency surgery on this patient and get that barium out that needs to come out. But anyway, here's an example of a baby with, again, the esophageal atresia. So we have the esophagus. In this case, they have a endotracheal tube, so the baby won't aspirate. But here's the proximal esophagus. It doesn't pass beyond that. In fact, here's a little hemivertebra. We can see, or a spina bifida. Anyway, we can see a little slit in that vertebra. So this is one of the patient with vacral abnormalities. But this patient has a lot of GI gas. So we know that this patient has a proximal atretic esophagus with a distal gastroesophageal fistula. We don't see any barium going down into the lungs, so probably this patient doesn't have a proximal esophageal fistula. In this case, this is a more lateral view, and we've had the baby swallow barium, and here's barium in the atretic esophagus, the proximal esophagus. But we can see this really tiny fistulous tract leading to the trachea. And so this is barium within the trachea. And that will lead to something that looks like this, in which we have the atretic esophagus, but we also have a proximal tracheoesophageal fistula, so barium gets into the trachea and out into the bronchi. And we can see how this barium has gone into the bronchi. And again, this patient has, it looks like, a distal tracheoesophageal fistula because we have a large air-filled stomach. Okay, let's talk about pyloric stenosis. Pyloric stenosis is a congenital abnormality, but it doesn't present until later on in life. Usually it'll present between 2 and 8 weeks. Normally it'll present sometime usually around 4 weeks or so. Boys are much more likely to have pyloric stenosis than girls, and for some reason, and I don't have any idea what the reason is, this seems to be more frequent, or the most frequent, in firstborn boys. Now, that doesn't mean that girls cannot get this, and it doesn't mean that later children cannot get this. They can. Every once in a while, I would have a new sonographer that would come to me with a requisition from the emergency room, rule out pyloric stenosis, and she would say, "This is a girl. She doesn't have pyloric stenosis. We know that because it's a girl. Why are we even doing this study?" And you'd have to explain, no, girls can have pyloric stenosis. It's just much more common in boys. What happens with this is the circular muscles around the pylorus enlarge and they thicken. And so I've put a YouTube video on your eCollege folder that explains some of the pyloric stenosis and is pretty good for pyloric stenosis. But this circular muscle thickens and it causes an obstruction, or at least a very narrowed pyloric channel by which food can get from the stomach into the duodenum. So what happens is these patients tend to have vomiting. Um, just because the stomach gets filled, it gets extended, it can't get into the duodenum, and so the patient vomits it up. And not only is this vomiting, but it's projectile vomiting. These patients, it can be really impressive. They'll vomit that stuff across the room. Linda Blair in The Exorcist has nothing on some of these babies, except that this is non-bilious vomiting because the bile duct enters the duodenum distal to the pylorus, so we don't have the biliary juices that reflux back into the stomach. So what tends to happen is the patient drinks the formula or drinks the milk, and it sits here in this acidic environment of the stomach, and it just curdles. And then the patient vomits this curdled milk. Now, these patients, most of the time, we can press on them, we can palpate, and in the epigastrium, we can feel a little nodule, a hard little nodule that feels like an olive. That's very characteristic for pyloric stenosis, and a couple of our pediatric surgeons, that's all they needed. If they had a patient that presented with a history that sounded like pyloric stenosis, they palpated that olive. They didn't do imaging at all. They just took them straight to the operating room. It's interesting that in the United States, we tend to operate on these. In England, they tend to do supportive care, keep the patient hydrated with intravenous solutions, possibly feed them intravenously, and eventually this pyloric stenosis will shrink back and go away. On imaging, what we will see is thickening of this pyloric muscle. This will also appear to lengthen the pyloric channel, the pyloric canal. And we'll see this target sign on sonography, and I'll show you that on the next image. Please, please, please do not memorize the measurements for pyloric stenosis. That's why Al Gore invented the World Wide Web, so we have a place to look that up. So there's no reason for you to memorize those at this time. There are also a ton of other signs. Seems like every other week someone would come out with another sign of pyloric stenosis that we'd see on barium swallow or something, barium upper GI. Again, you don't have to remember all those. I don't remember all those. Some of them are fairly ridiculous anyway. So what do we see when the patient comes in? Well, again, the patient has hypertrophic pyloric stenosis. They're having a difficult time getting things through from the stomach to the duodenum, and so we're going to have a large air-filled stomach or a large fluid-filled stomach if the patient has recently eaten. Early on in the disease, because this is a progressive type thing where this progressively gets worse, we will see early on gas get through a little bit of gas get through the pyloric channel, and so you'll have a little bit of gas in the abdomen, but you still will see this large stomach. Late in the disease, when there's a complete obstruction, you might see this large air-filled stomach, and you won't see much gas to speak of within the remainder of the abdomen. The way we used to diagnose these was with a barium upper GI examination. And again, we'd have this distended stomach and then this long pyloric channel, very long and thin. Often we'd have 3 little stripes here instead of just, 2. There's all sorts of there's a little nipple sign up here. So like I said, there's a zillion of these signs, but basically this long, thin pyloric channel is what we would see on barium examination. Now, I haven't done a barium examination on a kid with pyloric stenosis in years, and I'm not sure if anybody's still doing those or not. We hadn't done them in my place for a long time. We do ultrasound on these kids. And ultrasound is very distinctive. It was funny because a lot of the adult radiologists where I was, because we had pediatric fellowship trained radiologists, a lot of the adult radiologists just hated these studies, and I always thought, yeah, these are pretty easy to see. I'm not sure why everybody dislikes them so much. But again, here's the pylorus. Normally, the pylorus is really not even hardly visible on ultrasound. But in this case, we have a long pylorus. This is measuring at least, about 2.2 centimeters, because I think they could even measure it back a little farther. So at least 2.2 centimeters. About 1.3 centimeters should be the maximum length of the pyloric channel. And the wall thickness, or the muscular thickness, is 4 millimeters. And about 3 millimeters is the maximum thickness that the pyloric muscular should be. Again, do not memorize those. You're not going to be asked those on an examination. It's just a waste of your brain cells. When we turn the transducer transverse, because this is a longitudinal look at the pylorus, if we turn it transverse, so it's kind of like we're cutting through the pylorus, this is what we see. We see this thickened, or we see the mucosa here that's shining brightly, and then around here is this thickened muscularis portion of the pyloric channel. So it looks like a bullseye or a target sign. Oftentimes what we would do is we would give the patient a little bit of sugar water or a little bit of formula, or actually not a little bit, as much as the patient wanted. Usually, because they're not getting nutrition, these kids are really hungry, so they'll just gobble that stuff down. And we'll watch and see if we can see if this pyloric channel opens up and see if any of this fluid passes. Here it's 2 minutes post-feeding, and they're showing us that this fluid is still all within the stomach, and this is pyloric stenosis. Okay, so that's pyloric stenosis. Let's talk a little bit about intestinal malrotation and midgut volvulus. And again, this is where I would really advise you to go back and look at Dr. Nunn's lecture. If you need to, go on to YouTube and look at some of these bowel rotation videos, because this is, again, an embryologic defect. It's a defect in the growth of the fetus as the fetus is developing, and this is something that is often asked on standardized examinations. But basically, on X-ray or on barium study, this is what the proximal bowel should look like. The upper gastrointestinal part. You have the stomach. Coming out of the stomach is the duodenum. The duodenum makes this C shape. You can see the C, because right in this part is the pancreatic head. And so the duodenum then comes up, and the duodenum must be in the left upper quadrant of the abdomen, higher than the inferiormost portion of the stomach, and behind the stomach. So this is necessary for the proper mesenteric attachment of the small bowel. Now, when the bowel in development does not completely go through its entire rotation, 270-degree rotation, we can get something called a malrotation. And so in the malrotation, here's what happens, is the duodenal jejunal junction is not up in the left upper quadrant behind and above the most inferior portion of the stomach, but the duodenal jejunal junction is somewhere down here. It's well to the right of the midline, and it just kind of continues on down this way. This is a malrotation. Okay, the important thing about a malrotation is it leads to midgut volvulus. Okay, so what a midgut volvulus is, it is a twisting of the bowel around an axis causing obstruction of that bowel. What happens is we get the small bowel kind of extending down on the right hand side. The cecum with the appendix is up in the right upper quadrant of the abdomen. The body makes these fibrous bands called Ladd's bands that will attach the proximal ascending colon to the abdominal walls so that this portion of the colon can't move. And what happens is, because we have no normal mesenteric attachments of the small bowel, this small bowel can twist around on an axis. What happens when it twists is it can occlude the vessels that are supplying and draining the small bowel, and will at least get venous outlet obstruction, if not arterial obstruction. And of course, that will lead to ischemia, which leads to necrosis of the bowel, bowel perforation. That can lead to peritonitis, and that can lead to death. And so this is an emergency. This is, if we suspect the patient has midgut volvulus, this is a surgical emergency. In fact, the consequences of this can be so dire that it used to be, if we were doing an upper GI examination for any other reason, or even a barium enema for any other reason, and we found malrotation of the midgut, they would take that baby or that small child into a prophylactic surgery and put the ligament of Treitz, or the duodenal jejunal junction, tack it up in the left upper quadrant of the abdomen where it's supposed to be. There has been some pushback on that lately. I've read that some pediatricians and some not very many surgeons really, but some pediatricians are saying, let's not be doing surgeries on patients who are asymptomatic, because some of these patients can grow up and never have a problem. So we will do what is called, and I forget what they call it, but it's basically anticipatory watchfulness, where you really watch these kids closely to make sure their bowel's not twisting. I think that's still a minority opinion, and the reason is because, say you're taking your child back to the old country to see your grandparents, you're on a transatlantic flight, it's maybe a 5-hour flight, an hour into it, this baby's bowel twists. By the time you land in London or wherever, it's probably going to be too late for this child. So this is a surgical emergency. We try to get to these before the bowel becomes necrotic and infarcts. So how do these patients present? A lot of times they will have very acute pain. When this twists, they'll have vomiting and nausea because nothing can get through again. This is a complete bowel obstruction. We get what we call a double bubble sign. So you get the one bubble is the stomach, the other bubble's the duodenum, because right here again, this is where the obstruction is. And so if you see that double bubble sign with no gas beyond that, be thinking midgut volvulus. When we do a barium study on this, the very characteristic pattern, and this is something you should recognize, is this corkscrew, or this 3 appearance. It's sometimes called the Z appearance or the 3 appearance. Most commonly it's called a corkscrew appearance of the duodenum. This is this duodenum wrapping around itself. A very characteristic appearance on midgut volvulus. There's nothing else that looks like that. On CT scan, this almost looks like a hurricane that you see on the weather image, because again, it's twisting around an axis, and so you have the bowel that's twisting on itself. Here's some of the mesenteric fat, is this darker area in between, and here's the axis of the twisting. The axis is usually the superior mesenteric artery, not necessarily always, but this is a very characteristic CT appearance of a midgut volvulus. but CT generally isn't necessary for the diagnosis. Uh, Generally, if the patient has the symptoms and has that double bubble with a complete small bowel obstruction, or or they'll take him to surgery, or they may go ahead and get a quick barium upper GI. And if we see this corkscrew pattern, then that's midgut volvulus, and that patient has to go to surgery. Okay, now Dr. Malik talks about familial adenomatous polyposis and Poids-Jaeger syndrome. We've already discussed this, so please see the my lecture earlier this week on imaging of neoplastic diseases of the intestine and the appendix for further information about those diseases. All right, we'll talk about necrotizing enterocolitis. Necrotizing enterocolitis is ischemic bowel disease, and this can be due to a number of factors. It can be due to perinatal stress. Remember, birth is a very stressful time for this infant, for this neonate. They're coming from one environment to a completely different environment. They're going from breathing, or basically not breathing, breathing in amniotic fluid, to breathing air. They've come through a really tight canal that squished their abdomen, their chest, and especially their head. And so these babies are going through a very stressful time. And so it can be due to hypoxia, perinatal stress, infection, or congenital heart disease, and that kind of goes along with the hypoxia. It's the most common GI emergency, gastrointestinal emergency, in premature infants. It doesn't usually present at birth because this is a necrotic condition, and it requires some time for that to develop. And so usually it develops 48 to 72 hours after birth is when it will present. And if the baby has gone 10 days of life without necrotizing enterocolitis, in 90% of the cases they won't develop it. Most commonly it begins in the terminal ileum and the right colon, but it can spread from there throughout the remainder of the bowel. 80% of these kids have pneumatosis intestinalis, and I'll show you pneumatosis intestinalis. And this is the physical finding that we see on X-ray and CT scan. In fact, it's so common that amongst radiologists, we will often use pneumatosis intestinalis and necrotizing enterocolitis interchangeably. Okay, that's not technically correct. Necrotizing enterocolitis is the underlying pathology that leads to breakdown of the wall and air leaking into the wall of the intestine, or pneumatosis intestinalis. So here's a very severe case of pneumatosis intestinalis, and what we see are this air lining, the bowel. It's within the wall of the bowel. It's not within the lumen, it's within the wall. It has a kind of a very distinct look. And this is quite severe in this baby. This baby is probably not going to do very well because this is a lot of bowel that's necrotic. This is probably a little more typical, although it's still fairly severe. I mean, it's fairly widespread. And what we see is this little bit of kind of bubbly air within the wall of the bowel coming across, starts down here in the right lower quadrant, as most of these do, and coming up and going in, through the transverse colon and up into the splenic flexure. Again, that's this lucent or this darker line that's lining the bowel. And this is a more typical appearance than the severe one on the left. This is a really bad pneumatosis intestinalis. Not only do we see air within the bowel walls, but air has also dissected into the portal venous system. And so we see air within the portal venous system. This is a really dire prognostic sign. This baby's likely to do very poorly, likely to not make it. In addition, the walls have broken down enough that you have this kind of a hyperlucency throughout the abdomen, and we can see that the abdomen almost looks in this case, almost like a basketball. Normally we call this the football sign, but this looks more like a basketball, and that's a pneumoperitoneum. That's air within the peritoneal cavity, kind of stretching out the cavity. So in this case, we not only have the necrotizing enterocolitis with pneumocystis intestinalis, we also have portal venous air and pneumoperitoneum, and so this child is in really, really bad shape. On CT scan, again, you see these little bubbles of air within the bowel wall. This is air within the lumen. Okay, the air within the lumen will tend to rise in the patient supine, so the air tends to go upwards while the fluid tends to go downwards and make this air fluid level. But this air is trapped within the wall, so it can't really rise. Now, Meckel's diverticulum is quite interesting, and especially to us radiologists. It's not very common. We don't see it often, but again, it's kind of an interesting condition. Meckel's diverticulum, as you'll learn when you go through Dr. Nunn's lectures, I know you all will, is the remnant of the vitelline duct. And everybody has a rule of twos for Meckel's diverticulum, and everybody's rule of twos are different. They have a lot of the same components, but anywhere you read, you'll read different rules of twos. The rules of twos that I'll put up here, just because it's fairly comprehensive, is these occur in 2% of the population. Meckel's diverticula are generally about 2 inches long. They are within 2 feet of the ileocecal valve, so within 2 feet, not they're 2 feet from it, but they're within 2 feet, and they're on the ileal side. Okay, so they're part of the ileum, but they're within 2 feet of the ileocecal valve. 2/3 of these have ectopic mucosa, and there are 2 types of ectopic mucosa. Gastric mucosa, which tends to cause bleeding within Meckel's diverticula, and pancreatic mucosa. 2% of Meckel's diverticula, remember only 2% of the population has it, but in 2% do Meckel's become symptomatic. And males are twice as often to get these as females. Now, we can't really see Meckel's diverticula on CT scan, on barium swallow, barium small bowel follow through, any of those. But where we can see some Meckel's diverticula is on nuclear medicine imaging. And what we use for nuclear medicine imaging is something called technetium-99m pertechnetate. Now, technetium-99m is the radionuclide that we most commonly attach to a pharmaceutical agent to incorporate within the body system, within the physiologic system that we're looking to study. In this case, this is just straight technetium-99m as it comes out of the generator. We have a molybdenum technetium generator, and we get our technetium right out of that generator, and this is the technetium just straight up. Technetium-99m pertechnetate is excreted by gastric mucosa. And so if we just inject a patient with this, the stomach will become hot because gastric mucosa secretes these. So what we are looking for is when we inject the patient, we are looking for something in the right lower quadrant to appear about the same time gastric mucosa appears and become darker as the gastric mucosa becomes darker. And this tells us that this is a Meckel's diverticulum with ectopic gastric mucosa. Now you may say, as have other people when we've suggested doing this, well, you don't pick up all the Meckel's diverticula with a Meckel's scan, because all you pick up are the ones that have gastric mucosa. And our reply is yes, that's true, but the ones with gastric mucosa are the ones that bleed. And so if you're concerned about GI bleeding from a Meckel's diverticulum, this is the study to use. And let me just say too, ectopic gastric mucosa with bleeding in Meckel's diverticula occurs early in life. Someone who has anemia at age 25 does not have a Meckel's diverticulum. Okay, it would have presented much earlier than that. So that is a good way to evaluate for Meckel's diverticula, for a bleeding Meckel's diverticula. Now, one of the problems with Meckel's diverticula is that they can also be the lead point for intussusception. And I've been telling you for several lectures now that we're going to talk about intussusception soon. And so here it is. Let's talk about intussusception. So we're finally at intussusception. Now, what an intussusception is, it is telescoping of one piece of bowel into another piece of bowel. And so in this case, what we see is part of the small bowel, the ileum, that telescopes into the cecum. This is the cecum here. This is the most common kind of intussusception. In fact, of all of the intussusceptions, 90% are ileocolic, where the ileum telescopes into the cecum. Intussusception is primarily a childhood disease, although adults can get intussusception, but 94% of intussusceptions are seen in children. We can also get, in addition to ileocolic intussusceptions, ileo-ileal intussusceptions, which is much more common in adults, and also colocolic intussusceptions. This is the most common gastrointestinal emergency in early childhood, from about ages newborn to 5 years old or so. Now, we talked about lead points before. We've mentioned that term. We said Meckel's diverticulum could be a lead point. We said that in children over 6 years old, the most common lead point for intussusception is small bowel lymphoma. What we mean by a lead point is when something is extending from, say, the small bowel in the case of an ileocolic intussusception, when something like a Meckel's diverticulum extends from the small bowel, then what can happen is that normal peristaltic contraction, those normal peristaltic waves, can push that along the bowel, and what happens is the bowel, or the small bowel in this case, in the ileum, will come along for the ride. And so when that lead point gets into the colon, the small bowel will also just come along for the ride into the colon. In children, we only find a lead point in 5% of those cases. The other 95% of the time, we call those idiopathic. Now, idiopathic intussusception is probably not really idiopathic so much. What we theorize is that the lead point in that case is usually the lymphoid tissue of the small bowel, called Peyer's patches, P-E-Y-E-R-S, patches, that become inflamed, become enlarged, and act as a lead point. But we can't really prove that, and so we just continue to call those idiopathic. So what are the symptoms? Well, an abrupt, severe abdominal pain, and this pain is colicky, so it comes and goes because you have peristaltic waves that kind of come and go. This is a serious condition because what can happen is when the ileum goes through this ileocecal valve, this becomes very tight. And with some more inflammation, this can incarcerate and cause vascular compromise. And it also can cause a bowel obstruction, small bowel obstruction, because this might become so tight that further bowel contents can't get through here. And therefore, the patient will often have vomiting, just like any other small bowel obstruction, because that can't get through. Often, we can feel an abdominal mass. Now, this is normally in the right abdomen, often in the right lower quadrant, but we can feel it if it's if this is intussuscepted enough up in, say, the mid-abdomen. Now, if ever there was a buzz phrase, this is the buzz phrase. So you'll probably never see this, but current jelly stools. I have never heard the term current jelly stools except in the context of intussusception. So if you ever hear current jelly stools, that's what it's referring to. And this is current jelly. It's a berry jelly that's kind of a deep red. And so, when I was taking my oral boards in radiology, the examiner was, for the pediatric radiology, was just ridiculous in how much history he was giving me. In fact, it almost irritated me a little bit that he was, giving me so much history, and that I wouldn't wait until I looked at the films. But he described just this scenario, young child with intermittent colicky pain where he pulls his knees up toward his chest, and he had these current jelly stools. And I was tempted to say, do you want me to look at the x-rays, or do you want me just to tell you what he had? So I did not end up saying that, but I was tempted. Okay, so what do we see on intussusception? We see a small bowel obstruction. So we have air distended loops of small bowel, and often we'll see a nipple where this intussusception occurs. We'll see this kind of mass-like structure and sort of this nipple within the cecum. So if we see a normal, fully air-filled cecum, then we know that there's not an intussusception. But in this case, it looks like there's a little mass within the cecum. Or we know that there's not an ileocolic intussusception. In this case, again, we have air-dilated small bowel loops, and we end up having a fairly good size mass up here in the right upper quadrant. This doesn't look as characteristic of an intussusception, but we don't see the normal cecum, air-filled cecum, and so in this case turns out to be an intussusception as well. We typically use ultrasound for the detection of these. We used to use barium enemas for evaluation of it. We've gotten to where we do ultrasound. It's so much easier, and we get, it's not uncommon to have the emergency room send us down patients that rule out intussusception. We don't want to do barium enema on all those that don't have an intussusception. But basically what we see is we see bowel, this is colon here, and then we see this small bowel invaginating within the colon. Okay, right here is some of the fat, the periileal fat. And if we look at it, if we turn a camera or turn our transducer, we see bowel, large bowel right here, small bowel right here, and this is some of that mesenteric fat that is pulled in within the small bowel. This is an intussusception. They're pretty easy to see on ultrasound, and especially if we can palpate it. The cool thing is, one of the really neat things about radiology is that we can often reduce these in radiology, so the patient may not even need surgery. We used to reduce them all the time with barium, and we see the barium going back in this. We have the colon, so we're doing a barium enema. Barium's coming all the way through, and here is the intussuscepted segment. And what we do is we just keep squeezing barium into this, and this will push this intussuscepted segment back to the cecum, and hopefully, if all goes well, we'll pop that intussusception back out. And when that happens, it's pretty cool because all the barium then just whooshes into the cecum, just rushes into there. I remember one of the most dramatic things that happened in my career was I was called in about 2 or 3 a.m. When I was in the Air Force, and radiologist in the Air Force, for a barium enema on a small child who they felt probably had an intussusception. Kid was probably about, I don't know, 2, maybe 3 years old, kind of a small child. He was an African American child, and I came in and looked at him on the table, and he was gray. I mean, they're just gray as gray could be. He was listless. His eyes were just kind of glazed. I thought the kid was dying right there. And I probably, I kind of wondered if I even should be doing this, or should I just pack him up in the ambulance and send him right to the Naval Hospital? But the Naval Hospital's 40 miles away. That's where they had their pediatric surgeons. So I decided to give it one try. Normally we will try up to 3 times. There's a whole protocol. I was going to give this one try, and I put the barium in and just prayed that the bowel wasn't already necrotic and that I was going to tear the bowel and this barium was going to go all over into his peritoneal cavity and the kid would die right on the table. But we found the intussusception and moved it back, and finally, just after I was sweating bullets, the thing popped out. And immediately this kid's normal color returned, his eyes brightened up, he became animated, he became cheerful. I mean, here was a kid that I thought was dying, and all of a sudden, this kid is walking around like nothing ever happened. It was one of the most amazing things I've ever seen. I got a really nice note from his parents that next week or something, and saying how concerned they were, and what a wonderful thing it was. And I was tempted to write a note, say, boy, you weren't the only one that was concerned, because I was terrified. But anyway, we can do this with barium, but we can also, and this is the way this is usually done now, do this with air, where we do a barium or we do an enema, but we just put air in and we push back this intussusceptum with air. And this way, if we perforate the bowel, it's not as serious. But again, it's a very impressive procedure that you see this being pushed back, and when it finally pops out of the colon into the ileum, then it just air just rushes into the ileum. And I've included a YouTube video that talks about intussusception and air reduction. There are people that are doing water reductions under sonography. I've never done that, but that's being done now in some places. Now, adults can intussuscept too, although we don't see intussusception often in adults, about 6% of the time. Now, in my experience, that's probably a low estimate. I would agree that symptomatic intussusceptions in adults, may consist of 6% of, the symptomatic intussusceptions. But we actually see a fair number of ilio intussusceptions that are in adults that are asymptomatic when we are going through and doing a CT scan for another reason. These seem to be usually self-reducing, and in fact, there are times when we would go through the abdomen, see one of these, then do delayed images through the abdomen, and it would just be gone. It would self-reduce, and so we eventually stopped doing delayed images because we saw it so often, and it would just go away. But when they're symptomatic, they may have this recurrent colicky pain, nausea, and vomiting. 80% of the time, there's a lead point that we can identify. Can be a tumor, either benign or malignant, but it can be a diverticulum or lymphoid tissue, more Peyer's patches. Even a foreign body can cause intussusception in an adult. But it's not near as common as in a child, and most of the time, you may see this sometimes on your reports, that there is a intussusception within the small bowel, In the absence of symptoms, this is considered not clinically significant. That used to be what we would dictate, or what I would dictate. Okay, celiac disease. Dr. Malik has talked to you about celiac disease. Celiac disease occurs in the duodenum and the jejunum more often than in the ileum. On small bowel barium study, what we see is enlarged loops of bowel, small bowel dilatation, especially of the jejunum. This is kind of the hallmark of the disease. And we'll see what we call flocculation of the barium. Now, what that is the barium is normally fairly thick and coats the walls of the small bowel. When we get flocculation, it means that there's fluid sitting within that small bowel, and the barium kind of breaks up and it doesn't coat, and it looks really ugly. The moulage sign, moulage refers to the makeup that stage actors used to wear, the real thick pancake, waxy makeup, and now we use it when we are making up patients for say trauma scenarios. It's the nasty looking injuries we give them, or we call moulage. But the moulage sign just basically means that the loops of the jejunum that are normally have a feather boa appearance now are, it's like you've spread this waxy thick makeup on it, and we don't see all those folds. In fact, they look a lot more like ileum. So we call that ileization of the jejunal loops, where the jejunum and the duodenum just kind of become featureless. In response to that, the jejunum says, boy, we are not absorbing near enough nutrients up, or the ileum says, we're not absorbing near enough nutrients up in the jejunum, so I need to get more surface area here. And so the ileum creates a lot of folds itself. And this is called jejunization of the ileum. Or as one of my attendings used to say, the jejunum looks like the ileum looks like the jejunum, and the duodenum just looks like hell. And so these are kind of typical findings for celiac disease. We really require biopsy for diagnosis of this, though. All right, I want to talk a little bit about a couple of conditions that Dr. Malik didn't have time to get to. The first one is something called Hirschsprung disease, or aganglionic megacolon. Now, I've never heard it referred to as aganglionic megacolon. I've just heard it referred to as Hirschsprung disease. But this is a disease that presents in the full-term infant early in the life. We say here the first 6 weeks, usually it's within the first week of life. Boys are 4 to 9 times more likely to get this than girls. It seems like boys always get the short end of the stick in gastrointestinal diseases, at least in the pediatric population. And for some reason, this is really rare in premature infants. I have no idea why, because usually preemies have a worse time with everything, but this is rarely seen in premature infants. But basically, we can suspect Hirschsprung disease if we have a failure to pass meconium stool within the first 24 hours. Now, meconium is what the baby has been ingesting throughout its time in the uterus. So mucus, amniotic fluid, bile salts, etc., form what's called meconium, and it's this kind of green, pasty looking stuff. But if the baby does not pass meconium within the first 24 hours, that's abnormal, and we can start to think that there may be Hirschsprung disease. Sometimes this is much more mild, and we won't see it until later, but the infant may also present with constipation. So what we see in a barium enema or in plain films is an enlarged colon with a transitional zone. And what we mean by transitional zone is this is where the colon goes from being enlarged to being either small or normal sized. So in the case of this barium enema, what we see is this very enlarged colon, and right here's the transitional zone. where it goes back to normal size. This is the aganglionic segment, and this is bowel that's peristalsing against this aganglionic segment. Now, often this aganglionic segment is very low within the rectum, and it's very difficult for us to see on barium enema. We always are careful to do, if we suspect Hirschsprung disease, to do images of the rectum with the balloon, the barium enema balloon removed. The other thing we'll see is if we do a barium enema and send the patient back to their ward and bring the patient back in 24 hours with, normally babies will have multiple bowel movements, but these babies will have significant retention of barium within the bowel on a 24-hour radiograph, and that's what I suspect this is. I suspect this is probably a 24-hour image. And the last condition I'll talk about is meconium ileus. Again, meconium is that basically prenatal poop. It's what the baby ingests in utero. If the child has decreased pancreatic enzyme production, then we can get what's called meconium ileus. And what happens is the meconium is usually kind of a soft, kind of pasty, a little bit sticky substance, but it becomes a lot more sticky and a lot more tenacious, I guess, where it sticks to things in meconium ileus, or when we don't have these pancreatic enzymes. And so we tend to see these primarily in cystic fibrosis patients. So most likely, if a patient has meconium ileus, they will also have cystic fibrosis. The obverse is not necessarily the case. Only 10 to 15% of cystic fibrosis patients present with meconium ileus. But that's still fairly large considering that most patients will not present with meconium ileus. Meconium ileus is kind of the opposite of Hirschsprung disease as far as radiographic findings. What we see is meconium that is inspissated, usually within the distal ileum, and what we get is this kind of frothy or soap bubble appearance down in the right lower quadrant of the abdomen, which is the meconium, the inspissated meconium, the real kind of where it hardens, becomes nodular. And we'll see proximal to that this small bowel dilatation. And because there's a small bowel obstruction, you can't get anything through that inspissated meconium. And because of that, the bowel has not been used, and so it hasn't been dilated or stretched out. And when we do a barium enema, what we see is what we call a microcolon. It's an unused colon because nothing has been through here yet to stretch out that colon. And so that's the characteristic appearance of a meconium ileus. All right, and that's a wrap for this one. I know that this is a kind of a long lecture, but it's hopefully a little bit interesting to you. It's a little bit something out of the ordinary, and I think it'll be valuable for you, and I suspect that you will be asked a question or two about some of this stuff on your comp or your step examination. So let's keep our babies smiling and healthy and doing their thing.